So how you liking Detroit?
I'm loving Detroit. Yeah,
Loving Detroit. That's
yeah,
awesome.
Detroit. I mean, outside of the cold weather in the winter time, it's a pretty cool city.
Okay. Yeah, love Detroit. Detroit's always got something going on. All right, we'll just give it a minute and then we'll get started.
Okay.
Hey guys, I'm gonna get started. Today we have a very exciting guest, Dr. O. He goes by Dr. O. His actual name is pronounced Dr. O. Hanaja. He is a MD. He also has his master's in public health. He's a family medicine resident in DMC out of Detroit, Michigan. He's actually from Dallas, but he's doing his residency at Detroit, Michigan. And he's specializing in sports medicine. He serves as a personal fitness trainer, and he's also the member of the American College of Sports Medicine, and he's a strong advocate for sports and lifestyle medicine. And in tonight's call, if you guys have any questions, be sure to drop them in the chat as we go, and I'll try my best to get them answered as we go, or something specific, I'll wait until the end to get that answered. So yeah, drop them in the chat if you guys got anything that you want to ask, and that usually makes up for a really good session. So I'll let Dr. O get started.
I hope everybody's doing well. So I have a little case study here, case study presentation that I worked on, and it's really the basis and foundation of what we do here in sports medicine, with how we treat, diagnose, and evaluate, and even rehab athletes for different sports. So this presentation that I'm giving, it's called the Case Study Series in Sports Medicine. So basically, what I'm going to do is I'm going to go through different aspects of sports medicine and how it's operated in the outpatient setting, and how I kind of have been involved with it in either my family medicine practice or even working with sports medicine or even as a personal trainer, and giving you guys some insight onto some of the common things that people in sports medicine interact with and deal with on a daily basis. So the first thing is, these are just some objectives of some of the things that I'm going to be talking about. I know everybody may not exactly be quite familiar with all the different medical terminology of different conditions, or even some of the injuries, or even the anatomy and physiology, but I'll try to make it as simple as possible and try to give you the main highlights and high yield information regarding all of the slides I'm going to be talking about. And if there's any questions anybody has during any of the presentation, please do stop and put it in the chat, ask me a question, and we'll try to see if we can get to it at the end of the presentation, and go from there. So the first thing I want to talk about is called the PPE. Now the PPE is an abbreviation for what we call the pre-participation examination. So in sports medicine, um, every athlete has to go through some sort of pre-participation examination before they begin the sport. And the main reason for this is we want to try to screen and treat conditions that may be life-threatening or disabling to that athlete. And we also want to make sure that we're treating for conditions that might predispose that person to injury or an illness. An example of that is, maybe if we do a heart examination and we find out that they have a rare type of heart condition, what we like to call heart murmur, that could maybe predispose them to sudden death if they were, for example, playing basketball and running down the court, overexerting themselves. So that's also a very, very important thing that we like to do. Secondly, we like to do this pre-participation examination to determine the general health of the public, and it serves as an entry point for the healthcare system for different young athletes and adolescents. And, something like this can kind of be used to initiate some discussions about sports medicine related topics. So, in terms of the pre-participation examination, there are several things that can happen with an athlete that cause them to be restricted from playing a sport. Majority of them are usually musculoskeletal, meaning related to their muscles or their bones. Also, like I mentioned before, cardiovascular. There's a lot of different conditions that are related to the heart that can restrict the player from participating in a sport. And in the clinic, and you'll see that elevated blood pressure is one of the most common cardiovascular abnormalities that you find during this pre-participation examination that you're doing in the clinic. And this participation examination that we do is usually 6 weeks prior to the participation of a sport. So say, for example, us as a group of sports medicine physicians or even general physicians going to a high school to do pre-participation examinations on a football team or even on a girls volleyball team or softball team. We'll start that 6 weeks prior. And what we talk about is we try to ask the athletes different questions about symptoms that they have, maybe when they're exerting themselves. We'll examine their heart, listen for if they have any murmurs, and we'll look for different conditions that are associated with different heart murmurs. One of them is Marfan syndrome. I'm not sure if anybody's heard of it, but it's a particular condition where it's a defect in one of the proteins in the heart, and then also it predisposes people to have longer limbs and also defects of the aorta, which is in a valve of the heart. So athletes usually with systolic blood pressures less than 160 and the diastolics less than 100, they shouldn't be restricted from participation. But athletes with well-controlled asthma that are just, you don't have any symptoms at rest or with exertion can usually participate in a sport without any issues. And we usually don't try to order any type of blood or urine tests when we're doing these type of examinations, especially if they're asymptomatic athletes. It's more so about the holistic picture of the athlete, looking for some of these larger things that could restrict them from playing. And some of the things that you can encounter are, a player coming in, for example, you have a basketball player, they're complaining about some chest pain or tightness, maybe excessive elevated blood pressure in the clinic, or maybe we, had some history of a physical recognizing a heart murmur. Another thing that we do here in medicine is we always look at a person's family history. So if you've had a person in your family who's had a premature death, like, for example, I had an uncle, who suddenly died, or, you playing basketball when he was 30. And then we would document that, because that would be a definite red flag that you might likely have a similar condition. And in addition to that, you can look at different conditions from Marfan syndrome or different disabilities of the heart that can also restrict the player. So like I've mentioned before, we don't do blood or urine tests. And another thing we don't do is we usually don't do any EKGs. And EKGs are basically just the electro monitors that we hook up on the chest that measure a person's heart rhythm. So it's not recommended based upon our guidelines, but what is recommended is to look at these 14 points of common symptoms and common red flags that are often occurred in the sports medicine setting. So to give you an example, here's a question. All right, so this question is a clinical question, and I'm not expecting anybody on this chat to get this. unless you've somehow already encountered this somehow. The question reads: Examination finds findings of a 17-year-old male athlete with near syncope and suspicion for hypertrophic cardiomyopathy would include the following. So, hypertrophic cardiomyopathy, that's one of the main conditions, heart conditions, that can lead to sudden death in athletes. And it's a very common condition in athletes, and it's a very common cause of sudden cardiac death. So, in terms of what you would hear if you had a stethoscope and you put it on a person's chest, we have different types of murmurs, and each murmur can indicate a particular type of abnormality in the position of the heart. So, with this murmur, we have a crescendo decrescendo murmur, right? And it's associated with the Valsalva maneuver. Okay, so it's a crescendo decrescendo murmur, and by crescendo decrescendo meaning it's whenever you hear the first heart sound, it goes up, right? It's like a high pitched sound, and then after a while, it comes down, and the left sternal border would be at this position, right? In Valsalva, and by Valsalva, picture yourself swallowing and bearing down like if you're maybe like sitting on a toilet, right? So that's the Valsalva maneuver. So that maneuver can have the effect of changing the direction of blood flow. So with this particular cardiomyopathy, meaning like a heart condition, we hear the crescendo decrescendo murmur. All right. So in terms of, like I said, the hypertrophic cardiomyopathy is one of the most common ones, right? 36% of sudden death in young athletes, less than 35 years old. And just like I mentioned before, it's a crescendo, decrescendo, systolic. And by systolic, I mean the systolic portion of the heartbeat is the portion of the heartbeat that is pumping the blood, and the diastolic portion of the heartbeat is when the heart is filling. So this happens during the pumping motion of the blood, and like I said, it's at the left sternal border and it increases with Valsalva, right? So, but the main thing with this EKG, 75 to 90% of people will have an abnormal 12-lead EKG. But there is no characteristic pattern with this particular heart condition. So the best way for you to diagnose this would be to do a echocardiogram, which is basically an ultrasound of the heart. So they take a probe, they put it against your chest, and on the screen it will reflect an image that is using the sound waves from that probe to detect any type of fluid or motion abnormalities in the heart. And usually what we do is we try to manage this by giving the patient beta blockers. So beta blockers are a particular type of medication that work on a portion of the heart vasculature that block the beta cells or the beta receptors. And this is the first line management for hypertrophic cardiomyopathy. Another condition that you can encounter also in the sports medicine outpatient setting is something called commotio cordis. So for anybody who's ever played baseball or watched baseball, this is very common actually in the little league and younger adult population. It's due to a blunt chest wall trauma. So imagine, we have a young player at the mound. The pitcher winds up and throws a pitch and hits a line drive, and it hits the pitcher in the chest. So this is actually a very, very dangerous condition, and it's most common in people, like I said, less than 16 years. But before we had the onset of like early defibrillators, this was actually a cause of death because at that time, um, if you hit your chest in a particular portion, you're predisposing that person to something called an arrhythmia. So your heart just starts to beat, and it's not beating in proportion, and that's very fatal for your body. But with the onset of early defibrillation and use of defibrillators, especially within less than 3 minutes, this has been a very treatable condition. And because of that, chest protectors um, were tried to see if, okay, maybe this could prevent the commissio cordis event, but it hasn't really shown to be any type of use for prevention. So um, the next condition that you can also talk, we can also talk about in the outpatient setting is something called Marfan syndrome. Now, I already talked about that a little bit in the previous portion about how this is one of the most common things that we try to screen for in the outpatient setting. So basically, a person who has Marfan syndrome, they'll have very, very defining characteristics that will make them stand out, even if they would just walk into your clinic. They'll have hyperextensible joints, so they could take their finger, bend it back, contort their joints in different ways. They'll be very tall. They'll also, if you do a physical exam on them, they'll have anterior, meaning the front portion of their chest wall. It's going to be a little bit deformed. If you look at their back, they'll have scoliosis, and they'll have like a curvature of their back, almost like an S shape. And their arm span is greater than their height. So basically, if you took both of their arms, imagine if you took both of their arms and you kind of put them together, both of their arms combined together would be greater than their height. So one of the main complications of Marfan syndrome is that they'll have defects of their aorta in their heart, which is just a valve of the heart, and that can be fatal for the person who has Marfan syndrome if they don't know about that. So the main thing that we try to look for is we try to rely on the physical exam to screen this patient. And then if we suspect that, then we can move on to doing an echocardiogram, which I mentioned before, is the ultrasound of their heart. And you kind of looking at their heart to see if there's any type of abnormalities in the valves of their heart. Another way we can do is we can do a slit lamp exam, which is an eye exam, and 60% of those show that their lens subluxes. So they have 60% lens subluxation. All right. So now another condition that we can sometimes also run into in the outpatient setting is something called exercise-induced bronchospasm. So basically, this is usually seen within a lot of athletes. Maybe if they're in a high endurance sport, they'll be running, and all of a sudden they'll have bronchospasm. Their chest will start to tighten up. They feel like they can't breathe. So we try to manage this with telling athletes to maybe just try to do a little bit of like a light warm-up exercise, maybe doing a short-acting bronchodilator, right? And that's usually like albuterol, if anybody's ever had asthma. You try to use that 15 minutes prior to the exercise. If the short-acting bronchodilator is needed daily, then you probably need to add something called an inhaled corticosteroid, right? Or maybe if they have some sort of like sign or symptoms of leukotriene or maybe like an inflammatory condition, then we can try to move on and add these different other medications like the mast cell destabilizers, right? But this is the main type of treatment that we try to give these patients, and there's different grades of it. So these FEV, grades are basically just measurements of how much breath is expelled within 1 second, basically. So, right. So if it's severely reduced, greater than 50%, then you basically are at a severe level, and you more likely going to manage that more aggressively. Um, Infectious mononucleosis. So this is the infamous kissing disease called mono that sometimes is more present in the younger adolescent population, and the danger with this condition is that kids or even adolescents or even young adults, when they have mono, they have splenic swelling, and they're at risk for splenic rupture. So this is more important for players who are, in sports like football or hockey, those high contact sports. So a 21 day post diagnosis may resume light aerobic activity, because during those prior 21 days, they're at very, very high risk of having splenic rupture. So that can be very, very, very dangerous for the player. So we usually try to recommend them returning to play after 21 days. Now, um, this is another question, right? So you are a team physician at an early preseason practice when a 17-year-old male stumbles off the field late in practice. He's overweight, he appears fatigued, and he's sweating profusely. He's clumsy, mumbling incoherently. The trainer takes an oral temperature that is 102.1 degrees Fahrenheit. So the defining characteristic distinguishing between heat exhaustion and heat stroke is which of the following? So this is a very, very, very common distinguishing factor. So basically, the defining features between heat exhaustion and heat stroke. With heat stroke, you're going to have things like CNS dysfunction. By CNS dysfunction, it means like altered mental status, central nervous system. That's what CNS stands for. So basically, there's a grade of heat illness, and when you're working with players who are playing in, very, very warm climates, this was in, very popular in Texas where I grew up. You have, different grades of what, people would encounter with athletes. So, if it's a very mild, heat illness, it'll be anywhere from like heat cramps to heat syncope, or even heat exhaustion or heat stroke, right? And the main thing is if you suspect that they have heat stroke, you see a player, he's sweating profusely, or he seems very confused. The main thing that you want to try to do is you want to get a rectal temperature. You want to do that fast because more than likely, people are going to be too happy about getting a rectal thermometer stuck up in them. So, but it could be very life saving. You try to manage this by removing that person from exercise. You cool them down, you hydrate them, and you want to immerse them in ice as soon as possible. And that can just prevent any type of complications from having more brain changes, or damage to their muscles, or even more like damage to the rhythm of the heart. So, which of the following statements is true regarding sports-related concussion? So, is it A, B, C, or D? Well, you look at all of these, right? So, the first one's talking about return to sports can occur prior to the baseline academics. Maybe not, but if you look at the second answer choice, physical rest is recommended until all symptoms of sports-related concussion have resolved. Yeah, I mean, obviously you would want to recommend a player to rest before sports-related concussion has resolved. Or is it physical rest is recommended during the first 24 to 48 hours post-concussion? Or is it the overall duration of the SRC symptoms is the same in children, adolescents, and young adults? And the actual answer to this is, as we can see, right? It's going to be C, actually. So, okay, because you want to recommend the person to rest for a very short amount of time, right? But as we see, when a player has a concussion, you recommend them to rest for a short amount of time and then gradually work themselves up to getting back to their baseline, right? So, if for anybody who hasn't heard about a sports-related concussion or what it is, it's basically just a traumatic brain injury, and it's just caused by biomechanical mechanical force. You'll see this a lot in football. Somebody's going for a catch. There's a helmet-to-helmet hit. Two players go down, and they're taken off the field. They're a little bit woozy. All right, so we see this more often in contact sports like football, rugby, or even hockey, or even soccer. And one of the most common symptoms you'll see is like somebody having a headache. They'll be dizzy, they'll be confused or disoriented. A small percentage of the time, they'll lose their consciousness, and but it's not very often, right? And it's something that we need to keep in mind in this. Like, we don't really rush to have them imaged with a CT scan or an X-ray. We try to just diagnose it mainly based upon physical symptoms. And one of the best tools that we have or to measure sports-related concussion is called the SCAT-5, and we do this on the sideline with the evaluation of the athlete, right? So with this, we don't have any same day to return to play for an athlete with a concussion if we do diagnose them with that. And neurophysiological testing is just another tool that we just use additionally with this instrument of SCAT-5. And so basically, like I said before, we recommend them to rest and physically as well as cognitively. So if they're in school, we recommend them to rest and take a break from school, doing any type of homework or strenuous mental exercises or even physical exercises for the first 24 to 48 hours. And then we can gradually work them back into doing light activity that remains below the symptom threshold. And you want to return them to their academic baseline prior to returning them to play. So when an athlete can tolerate about half an hour to 45 minutes of reading, cognitive activity without symptoms of exacerbation, then he or she can return to school. And then also we do a graded program of exertion prior to the medical clearance and return to play. So there's been quite a bit of evolution of the sports-related concussion and how we view it within the past years. About 80% to 90% of all athletes have a resolution about 7 to 10 days. So now there's been more research in trying to see what's the exact time frame of the resolution of symptoms. And from what research has showed, it's been about a week. But the rate of recovery, it varies between ages. So it's prolonged in younger athletes. Also, it's affected by the female gender, post-concussive migraines, and in addition to that, like children 5 to 12 years of age can take up to about a month to recover. So that's also been a very significant finding in terms of understanding sports-related concussions. So this is just a kind of like a graph giving a summary of what I was talking about in terms of the time frame of the return to play. And the next topic I'm talking about right now, as it relates to sports medicine and the outpatient setting that we see a lot, is eating disorders, right? So athletes have a higher prevalence of eating disorders than non-athletes, and possibly the reason for this is a lot of different sports require physical demands or even sometimes even weight requirements to perform well. So, but it's more than likely, as we've been studied, 18 to 20% of female athletes have the eating disorders, but it's also present in male athletes in about 8%. So what we try to do is we try to take a team approach. We try to get different specialists, whether it be an MD or a dietitian or a mental health expert, and have them come together and address different aspects of individuals' eating disorder, whether it be their own mental approach to why they have an eating disorder or how they look at it. And then, if it's their own diet, maybe they have a misunderstanding about certain things they can eat. The dietitian can kind of fill the gaps into that area. As far as an MD, we can come in, we can look at their different medical history, things that we can kind of address, and in terms of any things that they need medication wise, we can fill in that gap. But more than commonly, we see different comorbidities with eating disorders. One of them is depression, anxiety, OCD, which is obsessive compulsive disorder, and also substance abuse disorder. Additionally, one of the other things that we can see in the clinic is something called like an anterior shoulder dislocation, right? So about 70% of the shoulder dislocations are anterior, meaning they're frontwards, and about 90% of the anterior dislocations are usually caused by trauma. So a lot of times you can see it in football, players coming in, they're leaning with their shoulder to make a tackle, and then they have an anterior dislocation. But how we try to treat this is we try to do what's called an early reduction on the field, and basically just by putting it back and popping it back in place, and that's been shown to reduce pain and kind of speed up the recovery. So let's see. Another shoulder condition that we also encounter in the outpatient setting is called the femoral acetabular impingement syndrome. So symptoms usually are you have pain in your anterior lateral groin, which is you'll have like a C sign, right? And you'll have pain in your hip area, and it's reproducible when you're adducting and flexing your hip. And by adducting, I mean like moving it inwards towards the center. We try to manage this just by giving them something like ibuprofen. We'll put them through a short course of physical therapy, and then we don't usually try to do any type of surgical intervention unless it's very, very severe, but we try to manage it very conservatively. All right, so now next question. You have been invited to present a lecture on sports injuries in high school athletes. So which of the following statements would you include in your talk? Would it be A, or would it be B, or would it be C, or would it be D? All right, so now just looking at all of these answer choices, the one that obviously stands out the most would be A. Football has the highest injury rate, right? So if you look at the National High School Surveillance of Sports-Related Injuries, this is from 2017 to 2018, football clearly had the highest injury rate for high school athletes, even double than in the next closest sport, soccer. So high school football is definitely shown to have the highest injury rate in the U.S. And as sports medicine physicians, we try to make note of that and do what we can to address all the different things that can come with that. Now, the thing is, more than likely, these sports medicine related injuries within football or even just sports in general are coming mainly from competition rather than practice. And some of the reasons for that could be just because when players are in competition, they're going full speed, they're given their extra exertion, they're playing more minutes. So all those different factors together can predispose them to more injuries. So the most commonly injured body region, though, in these surveys that were done in the 2017 to 2018 were the head and face, and we already talked about one of them, the concussion. Another one would be the ankle injuries, and also the thirdly would be knee injuries. Now, when we're talking about knee injuries, the most commonly injured knee structure, percentage-wise, overall was the MCL, and the MCL is the medial cruciate ligament. It's on the inner portion of your knee, and that ligament is very, very vital for stability. This is very commonly seen in sports like football, basketball, or even soccer. So, and we try to diagnose all of these different knee injuries based upon different physical exams. So, this question is asking us which physical exam test is the most sensitive maneuver for the corresponding knee injury? A is the Thessaly test for the meniscal tear. Would it be B, the anterior draw test for the posterior cruciate ligament? Or would it be C, the McMurray test for the meniscal tear? Or would it be D, the valgus stress test for the lateral collateral ligament? Now, as we look to the next slide, right? So these are the best physical exam maneuvers. So these are the ones that are actually paired for each particular ligament of the knee. So for the anterior cruciate ligament, we do something called the Lachman test. Now the anterior cruciate ligament is the ligament that's in the frontal portion, and it helps control anterior movement of the knee. The PCL, or the posterior cruciate ligament maneuver, can be tested with the posterior drawer test. And now for the medial collateral ligament, that can be tested with the valgus stress test. And then for the meniscal tear, you can test that for with the Thessaly maneuver, or you can do that by basically using a single or double-legged maneuver. And these can, if you are interested in what these maneuvers look like, I don't have a video in here, but if you want to put them into a Google search, it can be easily found. But these are usually the maneuvers that we do on physical exam in the clinic to see if a person has any type of damage to their knee prior to actually ordering something like an imaging exam to confirm it. So now the next question is, which one of the following statements is true regarding ACL injuries? All right, so is it A, prevention programs are ineffective at reducing ACL injury? Is it B, bracing is effective in the secondary prevention of the ACL injury? Or is it C, in high school sports, football has the highest rate of ACL injury? Or is it D, surgical repair of an ACL tear results in lower rates of knee osteoarthritis? Now we have this another answer choice talking about football and its rates of injury. So C definitely stands out to me, and that is definitely true. So in high school sports, football has the highest rate, and in women's, it's soccer. So female athletes are actually at higher risk for ACL tears. And the main thing to note about ACL tears is that 70% of them are non-contact injuries. And even myself, like I had one when I was in high school. And these are very common in sports where there's a lot of traction and cutting. So football has the highest rate, but like this answer choice said back here, there actually are prevention programs that you can do or exercises to reduce your risk of having injury, particularly with female athletes, and something called neuromuscular training. So with neuromuscular training, what you do is you basically train the nerves and the muscles to act accordingly to react to different stresses in motion and direction in order to be more stable. But another thing to mention is that knee bracing, although you do see it a lot out in different sports, isn't effective for primary or secondary prevention of ACL injuries. So you'll actually see that. You'll see a lot of players who, or even some players who come in um, after they've had a knee surgery for their ACL, but they're wearing a brace. But research has now shown us that knee bracing for an ACL tear afterwards or even before is not effective for preventing ACL injuries. However, knee bracing for an MCL tear is actually been shown to be more effective. So that's a key thing to know. I do encounter this a lot. People asking me, like, especially if they have like an ACL tear, like, hey, I want to get this knee brace from a sporting goods store. I just tore my ACL. Do you think I should be wearing this one? And I'll be like, well, I mean, really, it's not really going to do you that much of a difference if you don't wear it. ACL tears don't really improve with the knee bracing, or so that's something to keep in mind. And another thing that we've been also noticing within years of research is that people who have ACL tears develop osteoarthritis, similar to whether the ACL is repaired or not. So even in female athletes who they've had an ACL tear and then they undergo reconstructive surgery, um, they go through the rehab process, but if they're not careful, they can predispose themselves to what's called an overuse of osteoarthritis years down the line. So, but if you're like a younger athlete and you are hoping to continue to play, surgical repair is still recommended in the treatment of choice for instability. But some research has shown that, like, okay, maybe if you're, an elderly patient, you have an ACL tear, you're not really that active, you have very, very minimal daily activities of living. Surgical repair at that point is elective because you're not really involved with anything that needs to be require any type of lateral or quick movements. So, but for the younger athletes and athletes who aren't involved in sports where there's a lot of lateral movement, surgical repair is the treatment choice for instability. All right. So, and this is just basically a case study of a knee pain in 10 years after an ACL tear within a female athlete. And this is basically just illustrating what I was talking about. This was a female athlete. She had a bicycle crash and she fell onto her left knee. So she had actually a history of an ACL reconstruction at the time that she was 18, right? And so basically, they did a physical exam on her, and they showed that she had well-healed surgical scars, um, but they were noticing some, she's still having some pain in her lateral knee. So the differential diagnosis was, did she have a tear of her ACL graft? Did she tear any of the other portions of her knee? So what they did is they did studies of some of um, her left knee, just looking at the bone structure and the ligaments. And basically what they found was severe osteoarthritis of the lateral compartment, right? So arthritis meaning inflammation of around the bone joint, all right, and some edema, so some swelling. So basically, what it was just showing that this particular athlete, after 10 years of having that reconstruction of her ACL, had signs of severe inflammation around her joints um, due to overuse. So basically, uh, and the thing with osteoarthritis is this is something that you don't really see in the clinical setting with very young patients younger than 30. And this is a disease of overuse and wear and tear over time. So you'll see it with the elderly and senior citizen population, but for a 28-year-old, this is something that's very rare. So in their assessment, they say that she has early advanced osteoarthritis at the age of 28 due to a combination of her previous ACL tear and interim overtraining, right? So a very, very important thing in the clinical setting that you need to stress with, these athletes who have these ACL tear is that you need to make sure that you let them know that, like, okay, well, um, you do need to rehab your knee, but years down the line, if you um, are not training properly, you're not resting, you're going too hard, you have a very high chance of uh, inducing this early advanced osteoarthritis. So, one of the things that we try to do, especially for the female athletes who are more predisposed to this, is to um, implement neuromuscular training programs, but at the same time emphasize that, okay, well, you want to make sure you're also addressing their bone health, their nutritional status, and making sure that they're overtraining, because a lot of them will be like, oh, okay, I want to go back and get back to full strength. I got to work 3 times as hard to get back to that time, when in actuality, when they're doing that, they're doing more damage to themselves than good. So this is something that is over the years we really didn't understand very much, but now with research we're seeing how over time, even though with repair of these different ligaments, they can be predisposed to damage over time if they're not properly trained. So this is a example of neuromuscular training. This is actually a medical student that I work with. She's now a first year resident in Ohio. And so she is here demonstrating some knee lunges and some step ups. And these are some basic exercises that are part of neuromuscular training programs. She herself, actually, she was a college athlete, college basketball player, and she tore her ACL. This was me doing a training session with her, and her demonstrating some of the exercises that are common for the neuromuscular training program. And if we look at this, okay, so we have all the different type of acute knee injuries that you can possibly encounter, or the more common ones that you encounter in the sports medicine clinical setting. And these are just kind of the mechanisms, their characteristics that you can use to differentiate them. Now, if we look at this question, it says this is actually dealing with an ankle injury, which is also very common in the clinical setting with sports medicine. So, if you have a 26-year-old male who suffers an inversion ankle injury and ambulates to the ED for evaluation, you find that he has a lateral ankle swelling and tenderness over the anterior distal fibula. So, the next best course of action includes: would you want to tell him to avoid using ankle bracing after his injury resolves? Or would you recommend him to have early range of motion for the ankle? Or would you tell him to, possibly don't even think about using any ibuprofen or NSAIDs? Or would you want to rush him to get an x-ray of his ankle? And, although, um, you know, trying to get a radiograph of his ankle might sound like a tempting answer. And this might even sound like a very, very, bad answer, because you're thinking, okay, well, this person's in pain. They possibly, maybe injured their ankle really bad, would you really want them to be telling them to move their ankle around? And the actual answer is yes. You do want them to move their ankle around. Early range of motion uh, improves recovery. That's what research has shown. And the initial treatment is you want to tell them to rest their ankle, ice it, elevate it, and then protect it with some sort of bracing, right? So um, in sports, lateral sprains are usually the most common. About 80% of them are lateral sprains. And so we also tell them to use NSAIDs, and NSAIDs, whether it be ibuprofen, Aleve, which is naproxen, reduce pain after their injuries, and also reduces their time to return to play. But ankle bracing is very effective for both the primary and secondary prevention of ankle sprains. Unlike when I was talking about with knee injuries, where knee bracing wasn't very effective with ACL injuries, ankle bracing is very effective for the primary and secondary prevention of ankle sprains. So what we try to do is give them graded exercise programs and something called proprioceptive training. So proprioceptive training takes account into the fact that your nervous system has particular receptors called proprioceptors, where that even if your eyes are closed, it tells you how to shift your body to avoid injury when you're in different ranges in space. So proprioceptive training takes advantage of this and helps you improve quick twitch muscle reaction and sensory reaction in different spaces and movements. So this is some example of proprioceptive training that I do with some athletes and clients uh, at the gym. So this is actually one of my good friends. His name's Ray Thomas. He's actually a engineer for Ford, but he's also an Brazilian jiu-jitsu artist. And this was proprioceptive training that I was doing for him to help him prepare for a jiu-jitsu competition. And what I was basically doing is here, just having him stand on this balance board and both with his eyes open and eyes closed, shifting him and his weight um, to different directions and having him quickly react to it. And this overall has been shown to improve ankle strength, ankle stability, as well as overall core strength to help prevent injuries. And this um, slide over here, this is also another a student who I work with. He's actually Wayne State medical student. His name is Julian. So he was here demonstrating another proprioceptive exercise using these dumbbells to do squats and balance himself. So proprioceptive training in itself, it not only helps with ankle injury prevention, but it can also help with even some injuries preventing from knee injuries or even core injuries. So this is something that I've done with some of my clients, and it's also a very integral part of lots of different rehab uh, regimens for different injuries. And you only want to get the X-ray if they have something called malleolar pain, or just basically pain in the region um, uh, of their ankle, and if their inability to bear any weight 4 steps at the exam, or if they have any type of tenderness or pain um, at the site that they're looking at. So these are just Ottawa ankle rules. These are rules that we use in a clinical setting to see if we really need to order that X-ray, or is this something that's just already straight from the get-go? We know that's going to possibly be high suspicion for an ankle injury. And these are some of the other things that we can encounter also within sports medicine. With different sports, we have an handlebar neuropathy, and this is usually seen with cyclists. You can have an ulnar neuropathy, which is with throwers and pitchers, and then you can also have something called the saddle neuropathy, where cyclists are sitting on their seats too long, and they get neuropathic pain or a pinching pain around the area where they sit. And then the last one is the peroneal neuropathy, and it's usually at the lateral aspect of the knee, and it's compression from like a tight cast or brace. And sometimes because they have that tight cast or brace on that lateral portion of the knee, they present with foot drop. Um, and this is also something else that you can also see with some sports who are particularly playing in warmer or have a lot of different heavy equipment, that infections can spread through direct physical contact or even sharing of fomites. If, for example, if they're a group of athletes who are sharing towels in a locker room, and you can have different skin infections. And one of the things that we try to do is we try to tell athletes to um, withhold from any type of contamination, and kind of just wait until it's adequately treated before returning to play, to avoid any type of spread of infections if they do notice that they have some sort of skin infection. And another thing that we can also see is something called the female athlete triad, or relative energy deficiency in sport. So basically, um, over the years, they've come up with this diagnosis, and they've noticed this with some female athletes. It's where some of them will come in and they'll have low energy, and they'll have menstrual irregulations and have signs of decreased um, bone, like osteoporosis, like bone density. So again, just like the eating disorders, we try to take a multidisciplinary treatment plan approach, using MDs and dietitians, as well as maybe even other PhDs in other fields. So basically, with the female athlete triad, um, you have all of these different factors, and we try to stress to the female athletes that they need to make sure that they're having the proper nutrition, getting the proper rest, not overtraining, and making sure that they're having the positive mindset to uh, continue to maintain their athletic performance in light of like the demands that they needed to take on, but making sure that they're keeping more of a more regulated approach to how they're training. So with the female athlete triad, there's different levels of um, uh, things that we look at. So basically, uh, with their menstrual regularities, it's coming from this portion of the brain, and we like to screen them at the pre-participation examination. And athletes with one component should be assessed for others. And if they do meet one criteria, we'll go a little bit further and making sure that they're not at any type of risk for any of the other factors like stress fractures from osteoporosis, or any type of issues with their weight. So, all right. So now, I believe that's pretty much the end of what I have for my presentation. Um, we can open up the questions if anybody has any.
Yeah, thank you so much for sharing all the information. That was really insightful and uh, descriptive. I have a couple of questions in the chat. Why did you decide to get your MPH as well, and how do you use the public aspect helps during your work?
Well, I decided to get my MPH because actually my MPH is in health management and policy, and believe it or not, like my focus when I was in grad school for my MPH was in behavioral health with the elderly population and functional rehab for patients who suffered from falls and getting them back to strength and both psychologically and physically to prevent any further injuries. So the MPH that just kind of helped me see healthcare from more of like a public view and also looking at it from a almost like a leadership aspect point where I could understand um, what I needed to do if, for example, if I wanted to open up some sort of organization or clinic, what type of obstacles or would I encounter or what sort of things would I need to do to be more successful to reaching a larger group of population. Whereas, when you're in, just medicine, you might not see that on a daily basis, just working in the clinic or working in an OR as a surgeon. You kind of lose sight of how you can be more um, successful reaching out to a population, what a certain population's needs are, how you can market yourself a little bit more, and what certain populations respond to, and kind of understanding all the different aspects of what goes into impacting a person's health, whether it be their mental health, their social health, their physical health, and so all those things combined, I feel like the MPH give me more of like a holistic look on how to be a healthcare practitioner.
Yeah, that makes sense. I have one more question. What are the pros and cons of doing sports, specializing in sports after family medicine versus PM&R?
What are the pros and cons of specializing in sports medicine?
Yeah, I think like he's asking like if you do family medicine or PM&R and you specialize afterwards, which one is better?
Okay. Well, I will tell you one thing. Like, and if you're going the family medicine route, it's one less year of training.
Yeah.
So basically, like, so if you're going the family medicine route, you would have to do 3 years of residency, and then a 1 year of fellowship. Whereas if you're doing PM&R, you're gonna have to do 4 years of PM&R uh, training, and then even if you want to do sports medicine, you're gonna have to do an additional year. So that's 5 years. So that's one thing. If you go through the family medicine route, additional pro to that is like even if you don't want to solely do just sports medicine, you want to delve into other aspects of whether it be urgent care, emergency medicine, pediatrics, gynecology, um, geriatric care, palliative care. You can do that as a family physician because you're qualified because you have that training. Whereas if you're into PM&R, I mean, if you want to go into sports medicine, you can do sports medicine, but the only really other option you're going to have is just being just a general PM&R doctor or a sports medicine physician. So you have a little bit more options, and
Facility.
in that sense. I guess maybe the con would be is like if you're not really into like OB-GYN, you don't like doing pap smears, you don't like doing deliveries, like you're gonna have to kind of just bear through and go through that and get through those blocks and required hours to do something that you're not really interested in, or if you don't really care about doing too much in the pediatrics realm, then you would have to do that. So I mean, I guess that's also can be looked at as a con, like you're doing you know training or doing hours in work of specialties that you're not really that interested in. Whereas in PM&R, you're just more so focused on something that you're more than likely going to be involved in more constantly after your residency. So that's kind of how I look at it. I chose family medicine because I felt like it would give me more options and what I wanted to do post residency. So even if I didn't want to do solely family medicine or solely sports medicine. I could have other options outside of that, but everybody has to make their own choice. You got to look at what you're passionate about, what you feel like you're really good at and talented at, and where you think you can take yourself.
Yeah, that makes sense. I think that is it for questions. Before we go out, I just want to thank you for taking your time and coming to the house and doing the session. That was really, really helpful and insightful for somebody doing sports medicine or just in general. And for the audience, we'll be continuing having sessions every week. Just stay updated from us through our Instagram. We'll usually post information about what the call is going to be and who the person is going to be and what specialty they're going to be. And all the information is through Instagram. So stay updated through that. And we'll see you guys next week. Thank you so much.